But there's some other things where I believe we can all agree, and I would hope my friends on the other sides of the dais as well, and that's incentive reform within medical care delivery to improve outcomes and achieve some cost efficiencies. Mr. Pickering, I noticed in your last line of testimony you seem to allude to this possibly being an area of common ground. Quote you, to be successful in the long-term, reform must address both the financing of care and the cost efficiency and quality of care delivered. So what do you mean by that?
I believe in the country today our healthcare system is very fragmented. When you look at some of the best practice private plans out there, there are integrated delivery systems that deliver the best care for the lowest cost. I think we need to try to model reforms to integrate the rest of our delivery system.
I am very proud to represent an area that has largely integrated systems. 5 of the 6 large medical centers in the state that I represent are integrated, primary care focus, and you are absolutely right. The Medicare data is showing we're achieving high outcomes for among the lowest cost in the country. Dr. Davis, what can we do to evolve our care delivery systems along this way?
Absolutely. One of the main thrusts of this would be to encourage the growth of private integrated delivery systems. We took our commission, as you know, to North Dakota, looked at the very fine results that you're getting with many of the integrated delivery systems in North Dakota. In fact, our estimates are that 50 million people would enroll in these private integrated delivery systems, and they have the ability to both improve care by the way they control chronic conditions in your state and have lower costs. Right now, a small business often doesn't offer these community health plans that are aligned with integrated delivery systems. They can only offer one choice. Once the employer decides to take their employees into the exchange, they have access to all of these community integrated delivery systems. So those systems don't have to invest in marketing, salespeople to go out and visit all these small businesses. All of a sudden they have an access to a much broader enrollment market, and they are the ones that are going to thrive in this kind of competition.
One question I've got involves the evolution of our reimbursement system. We've got literally a stunning disparity in reimbursements. I'm not just talking about the underpayment in certain parts of the country, but just the cost for which Medicare pays care on a per capita basis. 05 data shows that a Medicare enrollee in Miami, Florida, involved $14,000 in health care costs. In Rapid City, South Dakota, it was $5,000. You know, this is a program for the country, but basically we feel like we're surely not reaping the kind of support that goes to other parts of the country. There must be something going on that is driving this differential in cost that is not related to quality of care delivered. And in fact, from an outcome analysis, if I can make any sense of it at all, it's the more it costs, the worse it gets. And the lowest it costs, the better it gets. Now, how do we, Dr. Davis, how does Commonwealth try to address this overpayment? How do we ever get this straightened out?
Absolutely. We have a map of the United States that shows those areas that are over 125% of the median, and Miami shows up in red. All of North Dakota, you'll be pleased to know, is white and under 105% of the median. So I think we have to look at things like our update policy in Medicare and look at how we reward areas that have done a good job of integrating care, controlling chronic conditions, and apply some economic pressure in these areas that, as you say, are almost 3 times as high in terms of Medicare spending.